Ladies and gentlemen, welcome once again to IVF Around the World. It is a delight to welcome you all back. The numbers are climbing as we speak. We have Anna Maria with us, we have Atef, we have Christopher Marino. Hello, Humna Beg. Hello, Faraz. Hello, Ishmael. Hello to Janet and to Mark and to Rayad, to Reem, to Talia and to Zainab. You are all very, very welcome. I have to say that I'm really, really looking forward to today's talk because it welcomes back an old friend. It is absolutely fantastic to welcome Anastasia Mania. Well, I wanted to say from UCL, but that seems to be quite a long time ago now because she is in fact with King's Fertility. So Anastasia started her life at UCL, graduating molecular biology in 2004, and she's been involved in fertility treatment and research ever since. She stayed on at UCL working in the PGD team and did her MSc in 2007. I think I was probably her external examiner then, if I recall correctly. During her time at UCL, she got her first taste of research investigating chromosomal changes in embryos, an excellent subject to work on, but then I would say that. And then she started a clinical training in embryology at a large NHS teaching hospital in London, where she coordinated the PGD service until 2013. During this time, she became ACE and HCPC registered, and she's taught an honorary lecture at Imperial College London in the master's course on reproductive biology. She then joined a very successful private London unit. It doesn't say which one it was, so I don't know if she wants to keep that one secret or not, where she was a senior embryologist. And then she became team leader for the research group, and I know for a fact that she's published several papers. She is absolutely passionate, and I know that to be true, about improving pregnancy outcomes and applying the very latest research to her clinical work while caring for the patient. And now she is at wonderful clinic at King's Fertility, and it says here she's excited about the road ahead. So I don't know whether that's the road ahead in the next few years or the road ahead in the next hour, when she's going to tell you all about setting up a PGT service in the embryology lab. Anastasia, we are delighted to have you. Over to you.
Thank you very much, Darren. Thank you very much for inviting me, yourself and Shadi, IVF Company and University of Kent.
Professor, can you start recording the webinar, please? Oh, it's being recorded. Yes, amazing. Okay, we can start, Anastasia. Thank you.
Thank you very much for inviting me, and thank you everyone for joining. I am the lab manager of King's Fertility in the past 3.5 years. And although King's as an IVF unit is one of the first IVF units in the UK, over 30 years, it's only recently got a license for the PGT service over a year and a bit ago. And I'm going to talk to you about how we got the license, what we needed to do to prepare for it, and also, of course, that's from as an IVF unit, how we prepare to work with what we call transport PGT. So we don't have our own PGT in-house service, but we collaborate with UCAS accredited PGT center, because that's a requirement in the UK, and I'll talk to you a little bit about regulations as well. So thank you very much for joining me. I will have to go into PGT and what it is, because looking at my title, I've left it quite broad. So I need, for the purposes of people who don't know what PGT is, I'll go a little bit into everything we do at the moment, and a little bit on what we've done in the past. But obviously, Professor Griffin is the expert on PGT and genetics, so I'm sure he's told you all about it as well. Let me see how to press next. That didn't work. Oh, there we go. So PGT stands for Pre-implantation Genetic Testing. It has been around since the 90s. It has changed name. It used to be called, it was called PGD and PGS. PGD for Pre-implantation Genetic Diagnosis and PGS for Pre-implantation Genetic Screening. You'll find a lot of publications and studies on calling it PGD and PGS, so bear that in mind when you do your literature search. But more recently, since 2016 or 17, they've renamed it to PGT for different things. So PGT is a test performed to analyze DNA from oocytes or embryos to determine genetic abnormalities and HLA typing, which I'm not going to go into it as it's too complicated. We have PGT for aneuploidy screening. We have, which is called PGTA as short, PGT for monogenic and single gene defects, which is PGTM for short, and PGT for chromosomal structural rearrangements, which we call it PGT-SR. It began in the 90s, as I said, here in the UK as a PCR-based method to detect single gene disorders, and later on we added interface FISH, which I was involved in that in 2004 as part of UCL, and I was mainly for the part of chromosomal structural rearrangements and aneuploidy screening. And now the technology has changed so much and improved so much that we're on genome-wide technologies that have replaced the FISH and PCR that had their own limitations, and now we can test a lot more accurately and at a wider, much wider on the whole, a lot more, all the chromosomes and a lot more genes. So I will go through the technologies a little bit later on, but for now I want to explain a little bit about each process of PGT, PGTM, PGT-SR, and PGT-A, and what it means and what we know and what's the evidence. PGTM, which is the testing for monogenic disorders, needs to have a couple who have a defined genetic diagnosis for a particular mutation, a particular disease. Depending on the national regulations, you may require a license in order to proceed to test for that disease. And in the UK, we have a list of already approved conditions and mutations that we can go ahead and perform the PGTM for the patient without asking for special permission. However, if it's a mutation of a disease that is not on the list, we will require to apply to the HFEA, which is our regulators, and explain to them why we want to perform this procedure, how is it going to benefit the patient, and how is it going to lead to a healthy live birth, and that we are reducing the chance of disability for the offspring or death, basically. So these are the factors the main factors for the HFEA. The disease needs to be, the mutation needs to have an effect in the life of the offspring, a significant effect before they can say, yes, we're happy for you to proceed, or no. Once our authorities have authorized the particular mutation and disease, then everybody in the UK, every IVF and PGT clinic can go ahead and apply this test for this particular disease. Similarly, PGT for structural rearrangements, like you've heard Robertsonian translocations and reciprocal translocations, which are the most common structural rearrangements, should be applied to patients who either the patient, the female patient, or the partner carry a structural rearrangement in their chromosomes and they have an abnormal karyotype. Now, they wouldn't have an abnormal karyotype themselves, they would have a balanced chromosomal rearrangement, because if the chromosomal rearrangement was unbalanced, then that individual probably wouldn't exist, loosely saying that. However, when the gametes are formed in our body and we know that we have a balanced chromosomal rearrangement, when meiosis happens in our body in order to produce an egg, errors happen if our chromosomes are not aligned properly, and therefore instead of having an egg with the correct number of chromosomes, we have an egg with the wrong number of chromosomes, and hence why those patients with balanced chromosomal translocations have infertility. They may struggle to conceive depending on what chromosome is involved, may have more often miscarriages, or may have an abnormal live birth that doesn't go well. So for PGT-M and PGT-SR, the technology is very clear. The rules are very clear in the UK and internationally. And as long as you have a license as an IVF clinic to perform PGT, and as long as you have a collaboration with a PGT center, it's very beneficial to those patients to avoid passing on genetic disease, whether it's a mutation or a structural rearrangement. Now, the application of this technique of testing number of chromosomes or testing genes can be applied for patients who don't have any chromosomal abnormalities or rearrangements, they don't have mutations and they are perfectly healthy, but they cannot, for one reason or another, they cannot get pregnant. And that technique, that procedure is called PGTA, and it's PGT, pre-implantation genetic testing for aneuploidy. In the past, before this existed, and obviously still used, we have testing of pregnancies to see the risk of aneuploidy, or which means an unequal number of chromosomes. For example, the commonest one being trisomy 21, causing Down syndrome. Some patients that potentially already need IVF or have gone through many IVF goals may choose to use this technology, PGTA, in order to select the embryos in a different way. In the IVF laboratory, as an embryologist, we select embryos based on how they look. So a good quality embryo at any stage, and usually at the blastocyst stage, would give a higher chance of pregnancy and a higher chance of healthy pregnancy. However, even though we transfer good quality blastocysts, we can't achieve 100% success. And we also know that unfortunately, as we age, our gametes make errors in our body, and therefore we want to select those gametes, which become embryos hopefully later on, out of the equation, so we can select the embryos that are also chromosomally normal. So PGTA aims to increase pregnancy rates per embryo transfer and decrease miscarriage rates, which makes sense if we are transferring embryos that have the correct number of chromosomes. However, because we've been doing this technique in many different ways over the year, with many different techniques that have different sensitivity and specificity and accuracy, and we were also varied the time that we tested the embryo from day 3 to day 5, which I'll show you later on. Our trials are very new with the latest technology and are not necessarily supporting enough in evidence, as evidence-based medicine goes, that it would help the patient achieve a higher pregnancy rate per embryo transfer. So currently, there's a lot of debate going on in the scientific community on whether we should be applying PGTA to patients, whether we should be applying PGTA to all patients or some patients or subpopulation, and who are the patients who will benefit mostly from it. Traditionally, PGTA was applied to advanced maternal age patients, so with the age cutoff varies a lot, but we would say over 38 years of age, or some people over 35 years of age. We do over 40 and over. Recurrent implantation failure, which usually means 3 failed IVF attempts of unexplained nature, and severe male factor, which means that the sperms of suboptimal quality in a severe way, and recurrent miscarriage, which is unexplained, and it's not with normal karyotypes and no other blood clotting factors. So recurrent miscarriage, 3 or more miscarriages. So although we started referring patients to PGTA for those particular reasons, now, because of all the debate and the lack of evidence, I've quoted some PGTA trials on the slide, and not knowing if it's beneficial for everybody. We take it more as a patient-to-patient basis and case-by-case basis, and we only apply it specifically for a small number of patients. And we do warn them that this procedure, PGTA, is of limited evidence because it's quite new, and our HFA, with their authorities, consider it as an add-on. So we give them the information, we give them the evidence, we give them the risk and the technology, and then we tell them, would you still like to go ahead? I think I said enough in one slide. I think I probably need to move on. So because I have to explain PGT and PGT-SR and PGTA at the same time, because that at least in the UK, when we set up a surgery like PGT, we apply for all three at the same time. I need to explain all three things differently. They are very similar, but bear with me because they have differences as well. So, for example, PGTM involves developing a specific genetic protocol for what we call a workup for the particular patient with a particular mutation. So we need to do some preliminary work before we actually start the IVF procedure in order to have a test that is tailor-made for this particular couple and no one else. This can take, it depends on the PGT lab, but it can take up to 3 months. It depends on whether they can identify the mutation easily from relatives, if we need relatives, to add as much of information we can to make the test as accurate as possible. Once the workup has been completed, then it can be used as many times as we like on a real IVF case. For PGT and PGT-SR, we do not require a workup period unless the structural rearrangement for PGT-SR is so small that the current methodology cannot detect it. We find it extremely important to, as with all of our patients, to counsel the patient appropriately. And as I said before, we have to counsel the patient on several levels. First of all, they need to understand their genetic diagnosis and their genetic risks, if they procreate naturally or not. And that the best person to do that is a genetic counselor. Our genetic counselor is based in our PGT center, but it could be an in-house genetic counselor. Some of our NHS patients may have already seen a genetic counselor through NHS, which is our national system. The clinician has to counsel the patient relating to the IVF treatment. Not all PGTM or PGT-SR patients have an infertility problem. So the risks of and the processes that are involved in an IVF treatment are quite complicated, and the patient needs to know about them. The clinician will also need to inform the patient about what kind of evidence-based medicine we use, what are the risks of pregnancy. If a technique is not as evidence-based as other techniques, we need to mention it, i.e. PGTA, and then take informed consent. Regarding embryological risks, that's where I come in. I inform the patient on their embryological risks regarding how many embryos will become blastocysts, how many embryos will be able to test genetically, when are the situations where we won't test the embryos genetically, and why are we doing that? Are we weighing risks of damage versus risks of wanting to have a diagnosis? I often relate their journey to set examples of, if we collect 10 eggs, how many embryos do we expect to have developed, how many blastocysts, and then give them a realistic expectation of what they should expect. Some patients, very important to keep the expectations realistic. So some patients may think that collecting 10 eggs means 10 embryos might mean 10 normal embryos. And that's unfortunately not the case, as well we may have experienced through your work as well. relating counseling to genetic testing and analysis, and how we're going to analyze and what's the accuracy of the test is also something that the geneticist and the genetic counselor will do. And as I said, counseling relating their expectations and psychological support is something we do, all of us, all the staff in our unit, doctors, nurses, embryologists, admin, and geneticists and counselors and genetic counselors. So very important how you counsel the patient and you give them the informed consent they deserve. So how does it work? Who performs the genetic analysis? As I said, the current technologies are all mostly genome-based. The acceptable misdiagnosis rate is about 1 to 3%. So the test itself is very, very accurate, 97, 98% accuracy. And different, as I said, PGTM is quite tailor-made. So we could start from direct mutation analysis, which I'm not going to go into it. If you know a lot of genetics, I could spend another hour talking about the different techniques, and I may bore you. Lincoln's analysis, carrier mapping, these are the keywords you need to remember for PGTM. PGTA, currently we use next generation sequencing, or NGS, and that tests all the chromosomes, all the chromosomes in the cell. And obviously PGTSR also uses NGS, but there are other techniques that I've listed, and this is from the ESTRA guidelines that can be used and have been used. Now the techniques that are fading away are techniques that didn't give a very good accuracy and weren't performed. They couldn't test all the chromosomes, like FISH. But generally speaking, PCR is still a very accurate technique. Multiplex PCR, quantitative PCR, every single technique has pros and cons. This is something that the geneticist will explain to the patient. The PGT lab will already know, will already be using particular techniques, and this is something you as an IVF clinic or as an embryologist or as a clinician, you need to find out what it means, what are the pros and cons of each technique, and how it can help your patient by being by understanding it to start with. All the genetic laboratories in the UK need to be UCAS accredited, with clinical scientists that are specializing in genetics, competent, authorized, and potentially usually ISO accredited as well. The close collaboration between the IVF Center and the PGD Center is vital. Understanding how they work will help your patients understand better and yourself and make the best decisions. Yeah, I've written down here limitations just to remind myself of each technique in accuracy, ploiding, balanced translocations. But if I start going through techniques, it'll take another 2 hours. Apologies for that. I'm trying to. Oh, there we go. So, how do we remove the cells from the embryo, and when do we remove the cells from the embryo? What's the most commonly used technique currently? I'm displaying all three methods of removing a cell from an embryo at different stages. The first one you can see is polar body biopsy. Polar bodies are byproducts of the meiosis of the egg. So when in an egg, that's an egg in the picture, and that little thing right next to it is a polar body. A mature egg has one polar body, and that means that the egg has completed meiosis 1 and it has just ended meiosis 2. At this stage of the of this stage, we can inject or inseminate the egg with a sperm so that we can resume meiosis 2, and a second polar body appears if that has to show us the completion of meiosis 2. And hopefully we get 2 pronuclei in the middle of the egg, which means normal fertilization. That then is an embryo. The idea of polar body biopsy is that the original idea of the polar body biopsy is that by taking the byproduct of meiosis 1 and 2, which is polar body 1 and polar body 2, we will mirror what happens in the egg, but with being less invasive and without taking part of the egg, which is impossible. So it's a less invasive procedure, and we still collect material that is not used by the egg or the embryo, and in the form of two polar bodies. There are advantages and disadvantages to this. The advantage is that it's less invasive, and also it's done relatively safely with very low damage risk. The disadvantage is that we can only test abnormalities that happen in the egg, so we can only test the maternal side and not anything that happens in the paternal side. Also, there are few risks that the polar body, especially the first one, may fragment on day before we take it, and therefore we may not get a full result. So although the polar body should be 100% concordant to the egg, so if something missing from the egg, it will be in the polar body, and if something missing in the polar body, it will be in the egg. The reality of it is that if you have a bit of fragmentation, it may not be 100% accurate, or you may not get a result if the polar body is fragmented. So polar body biopsy was quite popular a decade ago, but the recent study, a STEAM study, doesn't show any differences between the test and control group in pregnancy rates. And I think unless you're in a country that does not allow you to manipulate the embryos for more religious reasons, then and the only type of biopsy that is allowed is a polar body biopsy, then most people in the world do not perform, as far as I know. Now, cleavage stage biopsy is performed on day 3 of the development of the embryo, 3 days post-fertilization, when the embryo is 6 to 10 cells, and therefore we can, by removing 1 or 2 cells of the embryo, although 2 cells has been criticized massively, we can test those cells and see what is either the mutation in the embryo or the chromosomal rearrangement or the number of chromosomes. Cleavage stage biopsy is not done anymore, as far as I know, as often, unless it's a particular indication like no blasters formation for PGDM, as I say, because of the high rate of mosaicism in the embryos. What is mosaicism? Mosaicism means that not every cell of the embryo at that stage will have the same chromosomal context, which means, or content. One cell may vary from the other, and if we have 2 cells or more that are different in composition of number of chromosomes, then we call it mosaic. If we have 2 different ones, we call it mosaic. If we have more than 2, we call it chaotic. Every single cell is different. Now, embryos, and that's also a huge subject. I could do a whole talk on mosaicism, and I like it. On day 3 of the embryo development, the theory is that the reason there is more mosaicism is because the embryo is deciding which cells are normal or not, and that's the theory of self-correction. And the idea is that mosaicism may lessen as the embryo divides because the cells that were wrong were naturally fragmented and disappeared, hopefully. And then the cells that are correct have divided more evenly and faster in order to comprise an embryo that has less mosaicism eventually at a later stage. Now, so hence why we've kind of abandoned this cleavage stage biopsy at this stage. We also have higher risk of damage as it is quite invasive. Also, we remove a lot more of the embryo. If we remove 1 cell out of 8, is a lot more from removing at the blastocyst stage 10 cells from 100. And then some papers may have shown no difference on the blastocyst rate after biopsy or not, but some papers may have shown difference. Now, blastocyst biopsy is what is done currently in most, as far as I know, labs in the world. A blastocyst it could be formed on 5 days after fertilization or 6 days after fertilization. It has about 100 cells, and it has two types of cells. The cells that are called, we cannot see them at the moment in this blastocyst, they will form the fetus, and they're called inner cell mass, and it's a ball of cells that sits on one of the sides of the embryo, a cavity, which is obviously in the middle, and cells all around the cavity, which are called trophectoderm cells, and will form the placenta. Now, the cells that we take for our biopsy are the trophectoderm cells, are the placental cells, and we know from many studies, and recently also Professor Griffin, that the trophectoderm is concordant, highly concordant to the inner cell mass. So by testing those cells in the trophectoderm, we keep safe the fetus, the inner cell mass, and the embryo has enough cells to propagate and continue developing and implant. So blastocyst biopsy is quite safe procedure because we take 5 to 10 cells out of 100. The blastocyst itself is quite rigid and can take a little bit of manipulation. And the more importantly, if we're doing PGT-A and PGT-SR, we have less mosaicism in the chromosomes, which means that less errors in the mitotic divisions as the cells divide, and hence we can have a more reliable result. I mentioned a little bit more information on how we prepare the biopsy dishes in the different stages, which comprises of very simple 3 drops of either a buffer media under oil. If it's on day 3, it's calcium and magnesium-free media because we don't want any of those cells to compact and because it's very difficult to remove them. If it's blastocyst or polybody, we need a normal buffer media that we use normally in the IVF lab. A single culture of each embryo post-biopsy is vital, as we need to identify that embryo with a unique number and identify those cells that go to the genetic lab. Everything is double witnessed contemporaneously in order to not make any mistakes on the identity of this embryo, so we can track it back and know which one is normal and one not. Currently, biopsies are solely done through a laser beam, and the exposure of the laser beam, the pulse length and width should be carefully addressed, and it depends on what type of laser you have and how it's been set up in order to know what size you need. There are different ways of doing biopsy as well, at the blastocyst stage or at the cleavage stage. There's many guidelines by ESRI on how to do biopsy in all different stages. We use laser method and mechanical method combination, but I need to do another lecture on it. So the cells are either placed in a tube if we're doing genome-wide analysis like NGS or PCR, which is what we mostly do, or the cells are placed on a slide if we're doing FISH and they're fixed on it. This is decided by your PGT lab, and I'll tell you a little bit about it later. Now, what results are we expecting from patients? For PGT-M, obviously it depends on how is the mutation inherited, if it's recessive or dominant, and then the genetic counselor will be able to know exactly what's the chance of inheritance for PGT-M and PGT-SR. Now, for PGT-A, which is the aneuploidy screening, the outcomes are relatively simple, although and I've gone through them. We either have a normal number, the correct number of chromosomes, and we call that normal or euploid, or we have an incorrect number of chromosomes, we call this abnormal or aneuploid, And the genetic lab will tell us if it's an extra chromosome 3 or a missing chromosome 21, and they'll tell us everything they know. We could also have a mosaic result, which means that the cells that we have given to the lab are not all normal or all abnormal. It's a combination of normal and abnormal cells, and therefore that result, is mosaic. If it's mostly normal cells in that sample, then we call it low mosaic. If it's mostly abnormal, we call it high mosaic. Low mosaic, there's a little bit of evidence in the literature internationally that low mosaics could implant, but at a lower rate than normals, and lead to healthy pregnancies. That case, if we only have low mosaic embryos in our clinic, our patients go through genetic counseling to see what it means, to understand very well what it means, and we will only transfer it after genetic counseling and only in the case there's no normal embryo. High mosaic results we wouldn't transfer, abnormal embryos we wouldn't transfer either. No result or inconclusive results, which is less than 5% in our clinic, or 5%, I'll show you later, could be either because the DNA was of poor quality and didn't analyze, or inconclusive, which is a no result usually, or inconclusive result is when there's a lot of background noise in the way they analyze, and they cannot tell us, they cannot read the result. Either way, or when we counsel the patient or for no results or inconclusive results, there is the option, we counsel them for the option of rebiopsy, but obviously a rebiopsy has more risks to the embryo and more risks of damage, and hence, depending on the reason they've done the genetic testing, we would assess the pros and cons and whether we would like to go ahead with rebiopsy. So we're very cautious. When we biopsy, we're very cautious. We would put the health and the viability of our embryo as the most important thing than to get a result, because getting a result and not having a viable embryo is not worth anyone's time or money. So we also counsel the patient on the risk of no biopsy if we don't have any blastocysts, because we biopsy at the blastocyst stage, or the risk of no embryo transfer, we have no normals or low mosaics, or in the case of PGTM and PGTSR, no normals for the mutation or the chromosomal rearrangement. Our PGT lab reports mosaics in a rather, I'm not calling them conservative, it is called conservative approach. There are two ways of grouping your mosaics. It could be, so instead of having a range of normal and abnormal, we have normal up to 20%, and then 20 to 80 will be the mosaics, and then over 80 will be completely abnormals in the presence of abnormality. In our lab, we do 30-70 splits, which means 0 to 30% is normal, 30 to 50 is low mosaic, 50 to 70 is high mosaic, and over 70% of the DNA being abnormal is considered abnormal. They would also, if they see mosaicism on chromosomes 16, 18, and 21, they would automatically classify them as abnormals, because those 3 chromosomes are involved in live-birth syndromes, Patau, Edwards, and Downs. Okay. So each clinic has their own policy transferring mosaics, so that's another decision you need to make before you set up your PGT service. So what's the first step when you decide to which PGT laboratory to work with, and when you decide what kind of PGT service to offer? The discussions would be around everything I've told you so far, and it would be in a multidisciplinary setting. You would need clinicians, embryologists, geneticists, nurses. Everyone needs to understand how we genetically test and how accurate it is, which patients to offer it to and why, which methodology we're going to use in the embryology lab and in the PGT lab, and when we're going to do the genetic testing. We should be looking at all the PCT labs available near us and look at their accreditation status. We look at their staffing levels, their approach to new technologies, what's their evidence or validation for the process and techniques, what's their internal data of all the cycles they've done so far, all the genetic cycles, and what are the KPIs, key performance indicators regarding healthy live births, misdiagnosis, reduction in miscarriages, which they may or may not want to share depending on the policies with other IVF units. Evidence of standard operating procedures, SOPs, and risk assessments is always part of everyone's quality management system, and they should be in place. Sorry about the noise, there's a helicopter landing on the first floor behind. Now, this is part of our lab. The second thing that one would do before providing the PCT service is have the equipment in the IVF lab. All equipment must be calibrated, validated, and serviced at regular intervals as per guidelines of good practice in IVF laboratories. A laser microscope, which is part of your ICSI setup, should be installed, validated, and serviced. A dedicated workstation for putting your genetic material safely and in sterilized manner should also be available. So the only procedure done on that particular potentially morning would be the PGT and nothing else. The type of biopsy needles that you would obtain for your biopsy. There is a variety of biopsy needles depending on which stage you're going to do your biopsy. You can have beveled biopsy needles, flat biopsy needles, inner diameter of varying sizes, and it's up to preferences. And what I did is I took a range of biopsy pipettes and I tried in my own setting each one of them and see which one suits me best. And tubing micropipettes are much thinner than the normal micropipettes that we use with embryos. They're usually 120, 125 micrometers, and they're also CE marked. Everything is CE marked on consumables and for IVF use only, and they're also packaged in a way that is sterile, very important. We have dedicated consumables for biopsy, which is the needles micropipettes, but also in our hood on our workstation, we only use pre-cleaned and sterilized consumables just for that procedure. So no one else will be using that pipette that you want to use for your biopsy and your tubing on that day. You will only use it for that procedure, and you make sure that it's DNA free. A freezer is very important. You would think the last thing you don't want to forget is how you store your genetic material in the IVF lab before it travels to the genetic lab, and that's a freezer. It's very easy to forget that bit, and not everyone has a freezer that is dedicated and it's only for lab use. You may have a freezer for food, but that's not what you want. And also, most IVF labs have uninterrupted power supply for everything, for your incubators, for your ICSI microscopes, but it's important to remember that uninterrupted power supply should also be for the laser microscope. Training clinical staff on PCT implication counseling and consenting we've kind of covered, and training embryologists on embryo biopsy and tubing is also very important, paramount, and it can take a long time, even if the embryologists themselves are of many years experience. Ideally, you would need an ICSI practitioner, although it's so that they can understand the ICSI microscope, which will be your laser microscope, but it's not necessary. And I have a biopsy practitioner who is not ICSI trained, and they're brilliant. So the initial stages of training will be workshops, conferences, observation days in other labs, and then it will be the validation period and competency assessment. That would be done. There are 2 more embryologists, always in pairs because they witness each other, and always happy because we are all happy. The validation of an embryologist would be on 2 parts. Validation for performing the embryo biopsy on training embryos only, which is embryos that have finished with, usually frozen, finished with treatment and are not of no other use but or need but to be donated to training. So these are the only embryos that we are allowed to train on, and the guidelines say 50 of those would be your validation period. 50 can be quite tricky, and if you're not a large clinic, finding 50 training embryos, even for a large clinic, is quite a big task. So I would recommend you start your training very early in order to be able to do that. What we assess is not only watching that embryologist performing the biopsy and what happens during it and commenting, but also that survival of the blastocyst 24 hours after, and the percentage of damage. The next stage of validation would be on the tubing technique, which is the placement of genetic material in the tube, which is mostly done currently. And the reason that needs its own validation is because it's very tricky to put 5 cells in a tiny tube under a microscope. And those cells, don't forget, are from the trophectoderm. And don't forget the trophectoderm, when it hatches, is very sticky because that embryo wants to implant, because that's the stage that the embryos implant. So 5 sticky cells in a tube can be very challenging. So the validation process involves the PGD lab. It involves part of after the biopsy, moving the cells into the tube after washing them, and then doing a control, which means just a negative control, which means some of the media from your drops into a spare tube for each one of your tubing process, and sending to the PGT lab. If you get more than 90% of the samples with DNA amplification and in your test tubes and 0 contamination in your control tubes, then you pass and you are allowed to tube. Really important. I have worked in labs that different people tube and different people biopsy. You do not have to biopsy and tube if you cannot, if your staffing level don't allow it. You can be just a biopsy practitioner, or you can be just a tubing practitioner. Currently, we work with people who are biopsy and tubing practitioners, like trained on tubing as well. The validation also involves understanding the science behind it. It involves understanding how to report results and what the results mean, as we explained earlier. It involves understanding the importance of contemporaneous witnessing for each embryo, not just the patient. Embryologists are used to obviously match the correct patient and with correct embryos, but this goes beyond just patient-wide witnessing. We're talking about embryo-specific witnessing. Which embryo is number 1, which cell is number 1, and which tube is also labeled as number 1. There are also the tubes are uniquely identified, and that's part of the guidelines, but with a unique code, which we also record, and they usually have the initials of the patient and the embryo number. We also obviously have our own unique identifiers on the paper. So after all this validation, and when the embryologist is happy, they're ready to split cases very cautiously under clinical supervision with a fully trained embryologist. Understanding, so the third step is the regulatory requirements, and obviously in order to, in the UK at least, in order to get the PGT service going, we need to apply to the HFA, and we need to show them all the documentation in place, We need to show them all the proof that our staff is competent. We need to show them that all our equipment is validated and ready to be used. We need to have a third-party agreement and a service-level agreement with the PGT lab. And then we need to submit all of the above and wait for the decision. That's why we've done the training. We started the training long before the applying for the license, because the license itself can take a bit of time, and also because they require all that evidence, at least in the UK. So find out what your national guidelines is and what your national requirements are, and you may modify the process of applying depending on what they need. So when we have in place all of our patient information leaflets for all the different techniques, and we have all the consents in place, the laboratory forms, the standard operating procedures, our process and equipment validation, our staff competencies, our risk assessments. What if something goes wrong? What is the risk of that happening, and how we can, what is our backup plan? What if my laser doesn't work one day? What's my backup plan? So all this needs to be in place. And finally, as part of quality control, we need to monitor that all these things work correctly. And initially, you will monitor it case by case. You will monitor the degeneration rates case by case, the no result rates, the mosaicism rates, the pregnancy rate, the miscarriage rates, the live birth rates, and neonatal outcomes. And obviously, you will monitor periodically in group, and you have an average degeneration rate and an average no result rate, and so on and so forth. And it's very important to have very good monitoring to know if you need to modify anything or not in your process to make it better. You would also have patient feedback questionnaires on the patients who have come through for the PGT process, and ask them if they're happy or they would prefer it to have more information or less information. You would also ask the genetic lab, maybe annually or quarterly, if they're happy with our communication, cooperation, and so on. I'm aware that time has passed really quickly. So the final step is to have a very clear PGT patient pathway. We have a PGT patient pathway for monogenic disorders and structural rearrangement, because it's slightly different reason why we're doing that, and we also require a lot more genetic information from the patients. And we have a slightly different one and simpler for PGTA, which is implanted screening for patients who don't have any genetic disease, but they just can't get pregnant, and we're selecting the embryos through ploidy. But the general pathway is, as I'm showing, an initial consultation with the doctor that will define the need for PGT, genetic counseling for PGTM or PGTSR to understand the genetic risks, PGT consenting to understand the remaining risks and understand what PGT is. That's done by me or any clinician. Genetic counseling is done by the PGT center. Initial consultation is done by the doctor. And then if it's PGTM or PGTM actually only, there will be the workup time. And then when the workup is complete, we will go to follow-up consultation to make sure everything is placed before we're ready to start the IVF process. Then the IVF process starts, and at every stage of embryo development, the embryologist updates the patient to make sure they're aware of where we are at, how many embryos we think we might be able to biopsy, and how everything goes. The results are usually, for us, takes 10 working days. All the embryos are frozen while we're waiting for the results, and we wouldn't start a FET cycle until we know what the results are and we know that we have a normal. The results are initially provided by the embryologist by phone call usually, and then we book a follow-up consultation with the doctor where they go into the results a little bit more, and also they go into the plan for the next step clinically. Genetic counseling is also available to understand any complex abnormalities, and then that's the pathway. I think in our place works quite well. So the final step, although, is to, as I said, split cases between the biopsy practitioners as we go live. All the cases for about a year, me and my colleague, who are both biopsy trained from previous many years, split all cases. We test equipment before every biopsy, that the laser works correctly, that is aligned properly. We may practice on training embryos to make sure that we can actually biopsy and our tests work correctly, and we KPI monitor per case. We analyze, we criticize, and we praise case by case. So, as I said, actually didn't say it. We do have a few PGDM cases, but most of our PGDM cases are referred to our neighboring NHS hospital, as they hold the NHS license to perform PGDM on the NHS. And since PGDM is a very expensive technique, we can do it privately, but we prefer to offer it for free if we can. So we refer them to them. We have a few cases, but I haven't pulled the results to show them to you. And we have some PCT SR. Most of our cases are PTTA, so it's selecting embryos for patients who've come through many times and successfully based on their chromosome number and not only the morphology of the embryo. We do it very cautiously, as I said, because the HFA considers it an add-on, and we tell them that it is an add-on right at the very beginning. We don't shy from it. We explain the evidence every single time, whether they understand it or not. We explain that it's still under investigation. We've actually starting our own PCT randomized control study, which just got ethical approval to see if, as we like to do evidence-based medicine as much as we can, and if we see a gap, a small gap, whether it's small or big or medium gap in the evidence, we would like to help. And therefore, we're going to very soon start our randomized control study, and therefore we have a lot more cycles than 43. But we're very happy with the number of patients we do. Our program is working really well, touch wood, fingers crossed. We offer PGT on fresh blastocysts that we create on a fresh cycle, and frozen, usually for patients who have many miscarriages and still have many embryos in storage, many blastocyst storage, and they're unsure of doing FET after FET after FET and not succeeding. It can be quite demoralizing. So we use this technology to select the best embryo based on chromosomes. So we got 29 patients, average maternal age of 39.7. The most common.
Yeah, I'm afraid we've got 1 minute to go and we've had no questions. I have to stop you.
Yeah. All right. Generally, we have good rates and no results. And then I was going to go into pitfalls and troubleshooting.
I'm afraid we're done. Sorry, we're way over time. So one question. Yeah. So one quick question. How big a lab do you need to, if you're setting up a PGT lab, what sort of space do you need?
If you're setting up a PGT transport, yeah?
Yeah,
you just need a hood, a laser microscope, and a freezer.
Okay, fantastic. So not very much space. So listen, everyone, we are rapidly running out of time. That just leads me to thank Anastasia for a lovely talk. We'll try and get the questions to you, Anastasia, if that's all right, because we had quite a number of questions. We're very grateful for you all to join us. Next week, we have Dr. Abayomi Ajayi, if I pronounce that correctly, and also one of our former students, Rowan, who is all from Dubai, and both of them will be doing a double act for us next week. So, ladies and gentlemen, we are coming up to the hour. It's been fantastic to have Anastasia with us, give us a very detailed and very enthusiastic talk. And with that, we will now sign off. Thank you to the IVF Company. Thank you to the University of Kent, to Mahesh, and to Shadi. Thank you very much. Goodbye.
Very much.